Good evening, everybody, and thank you for joining us for our TIF Talk Tuesday. We're very excited to have our special guest, Dr. Adam Dachman. Welcome, Dr. Dachman, and thank you for being here this evening.
Thank you for having me.
Of course. So a little background of Dr. Dachman. Dr. Dachman is a board-certified general surgeon who completed his medical degree at Des Moines University of Osteopathic Medicine and Health Sciences and surgical residency at Beaumont Botsford Hospital in Farmington Hills, Michigan. After years of receiving multiple awards for patient care, Dr. Dachman continues to focus on the doctor-patient relationship each day. As a national speaker on the subject, he considers time with patients to be sacred trust and bond, and providing patients and their families with excellent education. It's a top priority during his care. Dr. Dachman is affiliated with Watertown Regional Medical Center in Wisconsin and is accepting new patients today. To share some personal spotlight on Dr. Dachman, in his spare time, he is a composer and an accomplished concert pianist. I think you can find them actually on Spotify or YouTube, right, Dr. Dachman?
Yeah.
Okay. Well, please join me in welcoming Dr. Dachman to our TIF Talk this evening, and thank you for being here. So thank you so much. So as a reminder, this is a live event, and at any time, if you have any questions for Dr. Dachman, please feel free to type them into the comment section, and we'll do our best to answer them this evening. So again, welcome, Dr. Dachman. Thank you for being here this evening. Do you want to tell us a little bit more about your practice and where you, I know I said where you are affiliated with, but give us a little background on you and your practice.
Well, I have the pleasure of providing care to patients in central Wisconsin. My clinic is located in Watertown, which is between Madison and Milwaukee, right along the I-94 corridor. And we do a full general surgery practice. Much of my practice is devoted to the treatment of digestive health and disease, and a good portion of that is related to the treatment of reflux, which most people describe as heartburn.
Perfect. Yeah, we'll actually just dive right in and start talking about reflux and GERD, if you will. Maybe you can explain what does GERD stand for, and also, what are the symptoms that patients could potentially feel if they were suffering from GERD?
GERD just means you're having a really bad night. But
True.
the initials are gastroesophageal reflux disease, which is a medical term to describe what most people know as heartburn. And there you go. That's what that's what GERD stands for.
Thank you. What kinds of, a lot of people talk about, suffering from heartburn, and everyone knows that feeling after they eat. They can feel kind of this pain in their chest, but there's some other kind of symptoms, kind of atypical symptoms that sometimes patients don't relate to GERD, in the sense of, I hear patients going into the ER thinking they're having a heart attack, or they're having, severe pain in their chest or severe asthma. Can you talk a little bit about those kind of atypical kind of things that could come up because of their heartburn or GERD?
Certainly. It's an interesting subject. When you try to teach people about their symptoms, you're, for the most part, unable to point to something. They're not able to show you because it's going on inside their body. Not everybody knows what heartburn is. How do you teach something to somebody when you can't necessarily point to it? You can teach somebody what the color red is when you point to the color red on a board, but to teach them what heartburn is, not everybody has it. So some people are in that bracket of not knowing when they're having acid reflux. It doesn't show up as heartburn for everyone. So some of the other ways it shows up can be as a cough. Some people will have a mysterious cough that won't go away. Other people feel pain in their chest. Some people will have burning that they don't understand, and they'll describe it as a sour burning taste in their mouth or a sour burning in their chest.
Right.
Some people will wake up at night from sleep when they're laying down, and they'll have a sudden feeling of material coming up into their throat, and they'll sit up and they'll wonder what just happened, and it'll burn, and they don't know what it is.
Yeah.
Sometimes it's severe,
Yeah.
and it can be quite distressing. It can happen to adults and even children.
Yeah. So you get this question a lot from patients. At what point do you as a physician consider GERD being an actual disease state, if you will? I mean, everybody talks about having some heartburn every now and then. You eat a big meal and then you lay down, and everybody kind of has some sort of heartburn. But at what point is it, a disease state for them, and where they should do something more than just take their, occasional Tums every now and then?
Yeah, it's what I like to refer to as, when does the grocery store checkout aisle heartburn? Because in
Yeah.
the old days, you could always buy Tums or Rolaids at the
Yeah.
checkout aisle at the grocery store. Not so much anymore. Nowadays, it's all People magazine and the National Enquirer, and it's candies, etc. But it used to be common to find a roll of Rolaids at the checkout
Yeah.
counter at the grocery store. So when does heartburn become more than just an occasional event that you can treat with a kitchen remedy like Alka-Seltzer, Rolaids, or Tums? And the answer is, you kind of know when it does become more. It becomes frequent, it becomes disruptive, it starts to become distressing, where you're wondering, oh my God, I've never had this like this before. It's not going away.
Right.
I took Tums an hour or two ago, but it's wearing off and the burning's coming back, the pain's coming back. And now it's been going on for a week. What's going on?
Mm-hmm.
And this is a common experience for many people, where it no longer is something that's occasional and minor, but now it's becoming frequent, and it's disrupting one's quality of life. And they're suffering, and now they're looking for answers.
Yeah.
Sometimes they're even frightened.
Yeah.
So
No,
they
that's a
start
perfect.
looking for help.
Yeah. 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 No, that's perfect. And you kind of touched on it, the idea of going to the grocery store and picking up Tums or Rolaids. And now, people are, self-prescribing PPIs to themselves, a Meprazole, or whatnot, a Pepsid. Can you talk a little bit more about the differences of kind of just the Tums and Rolaids versus the Meprazoles and the different types of medications that are out there that people are kind of self um, prescribing to themselves, if you will?
Yeah, there's kind of, let me switch to a little blackboard or whiteboard behind me. There's kind of three categories of situations that people can use for their heartburn. The first one would just basically be antacids. Antacids, that would be Tums, Rolaids, we'll say Tums, etc. Can you read that, Dr. Handwriting?
Dr. Handwriting at its best.
So then later on, in about the 1970s, we developed drugs that we found out would reduce acid in the stomach, and we were using them for ulcers. And these were drugs that really changed everything. We called those H2 blockers or H2 antagonists. Blockers is more of a common term. And that was Tagamet and Zantac. And then there was Pepsid, and those are the most common ones. And then in the 1990s, we came up with a whole different class of powerful acid reducers that shut the pumps off in the stomach and make the stomach less acidic. And those were called the proton pump inhibitors, which we call PPIs. And the first one was Prilosec. And then after that, there was Prevacid. And then after that, there were a bunch of them like pantoprazole, which is Protonix, and Dexilant. And so this was the natural progression from the old days to the modern era. And then these drugs here and these drugs here became so widely used that they became over the counter. We realized they were very safe. Billions of people were taking them, and they went over the counter. So now you can walk into your local grocery store and find these things and use them. And a lot of people do. And so one of the questions comes up, which is, when are you using these too much? Mm-hmm. Or when have you used them for too long? Or when should I be alarmed if I've taken one of these for a while and it's not getting better? Should I do something like go to the doctor? And so that's where the rubber hits the road. And that's why this conversation tonight is useful, because a lot of people find out that doing this for a little while makes them all better, and they stop doing it and they're fine. And in those cases, I don't think people need to be worried for the most part. If it's an occasional thing and any one of these remedies helps, then I think it's time to basically just relax and not worry. But it's when these symptoms of heartburn or pain when you swallow or recurrent material coming up at night in bed or any other sore throat symptoms, or your voice changes and it doesn't go back to normal, those are the things you want to tell your doctor about.
Yeah, no, that was great. Thank you for that. That was helpful to see the different classifications of medications. I know it probably is very helpful for the patients that are watching. So with that said, there's been a lot of talk about, taking the medications long-term and having some potential side effects. Do you want to touch a little bit on that? There's some questions that have popped up, how many PPI is bad if I take them for too long, or how many Tums, if I take too many, how many Tums does it take where it's too much? Can you maybe discuss that just a little bit?
Sure. Everything I'm about to say is general. It's relative. It's a guideline. Okay. So what I'm about to tell you, I think should be used with a little bit of personal judgment on everyone's part who's watching this. So if you have heartburn after you eat a pepperoni pizza, welcome to modern mankind. Often people will eat a food and experience some heartburn afterwards. So you take a couple Tums. If it goes away, great, it's done, it's over. But what happens if one day you notice that every time you eat, you're having a horrible burning, and you start taking Tums or Rolaids or Maalox or Alka-Seltzer, and it helps, but it seems like it just keeps coming back. I think that's right there, your signal. Something else is going on. It's a little bit more advanced.
Sure.
So what's the next step at that point? Well, the next step might be a visit with a doctor or a PA or a nurse practitioner. It might also be a trip to the drugstore to get something stronger, like one of the medications like Zantac or Prilosec OTC, something that is for acid reduction. And those things are a little stronger. If you take that and it works, the question is, well, how long should I stay on it? Some people find out that they take it for a couple days and then they forget to take it on the third day and their symptoms come back. Well, you're not done yet. You should probably take it a little bit more. Consider taking the whole bottle. Maybe there's 14 pills. That's a 2-week supply if you take it every day. So you take the 2 weeks and you stop. Then you say, what happens? If the symptoms are gone and they don't return, you're probably done. And whatever happened has healed and gone away and gotten better on its own, and you're okay. But what if your symptoms don't go away and you find yourself now going back and buying your second bottle of whatever it is, and you're taking it for 2 more weeks?
Mm-hmm.
And you do that and you're okay while you're on the pills, and then you run out. And then you're off of it for 2 or 3 more days or a week, and then your symptoms come back again. Well, now it's different. Now something else is going on. Now it's probably an anatomy issue. Now it's structure.
Mm-hmm.
Now maybe something's different.
Yeah.
Your body might have changed. So let me go back to the board, if this would be a good segue.
Perfect segue.
To answer the question, how long should I be on medications? So I'm going to erase the board. Okay. So here we go, back to the whiteboard.
There we go.
So what are we talking about if medications don't work? Well, let's just consider the anatomy. So we basically have our neck here, and our esophagus comes down our neck, and here's shoulders here, and the esophagus goes down our chest, okay? And then at some point in our chest, the esophagus is going to become our stomach, okay? And here's our stomach. Now, somewhere in our chest, we have our lungs, and I'm trying to just draw this so that it all fits here. And we have a structure called our diaphragm, and basically our esophagus goes down through our diaphragm. There's a hole in our diaphragm called the hiatus, and then the stomach goes down into the esophagus goes into the abdomen, and that's where the stomach is. So this is the chest, and this is the abdomen. This is the chest, this is your belly. And so when you get burning in this area called heartburn, or you have fluid coming up into your mouth when you're sleeping at night, when you're laying down, or when you're upright during the day and you feel stuff coming up, what's happening is fluid or food down here in your stomach is going up here into this area where it doesn't belong. And this area here is filled with hydrochloric acid. And when this acid comes up here, the esophagus doesn't like it. It wasn't designed to withstand acid exposure for very long. And so when there's too much acid up here for too long, you start to feel a burning. You start to feel heartburn, or you start to feel pain. So when you swallow a Rolaids or a Tums, it goes into your stomach down here, dissolves, and it's a buffer. And it makes the acid down here more like water. It neutralizes the acid. And so it doesn't stop reflux. It just makes what's coming up less acidic, but it doesn't stop the reflux. When you take Prilosec OTC or Prilosec or omeprazole or famotidine or ranitidine or pantoprazole, et cetera, the medications your doctor prescribes, or the ones you buy at the grocery store or the drugstore, all they do is they just shut the acid off down here. They shut it down. So there's less acid in the stomach. But none of those medications actually stop reflux. The reflux stops when this particular area pinches shut. It's got to close. This area's got to close off to be a barrier. So when acid is here, it's supposed to stay here. Sometimes I teach patients that the stomach is like a fireplace and the esophagus is like a chimney. And there's a damper valve here in your fireplace. When you open it, the smoke goes up of your fireplace. When this valve is open here, acid could come up. It can be liquid acid. It could even be acidic vapors rising. If this valve here doesn't shut, people have acid reflux.
Yeah. I love that analogy. That's perfect. Fire and the smoke, because that's what it feels like probably coming up, right? Fire up your esophagus. That's a great image, and thank you for sharing that with us. Can you talk a little bit about what are the different tests that you will do to determine if a patient is ready to move beyond medical therapy and potentially a actual procedural therapy for their GERD or their acid reflux?
Well, one of the things I've learned in my 30 years as a physician is this. At some point in our life, we become a patient. And I've been a patient at times. And it can be frightening, and we get concerned. We want to be healthy. We want to feel good. We don't want to be in pain. We don't want to have discomfort. We don't want something bad to happen. And we look for answers. And so, first of all, when somebody is looking for these answers, it's important to understand that we doctors, we get it, we know. So when somebody comes to me, by the time they get to me, I know that they want help. And so we start with just basic history. What have you tried? What's worked? What doesn't work? We try to understand what they've been through and where they are. If they've gotten to a certain point, we want to evaluate what's going on to be causing them to have so much distress that they would actually be seeing us. So what we'd want to know is what's going on with the anatomy. We want to know what's going on with this area. It's hard to understand what's going on just by questions and answers, although questions and answers do work in the office. We generally want to see this area somehow. We want to examine it. Just like a doctor will look in your ear if you have an earache. If you got a bellyache or you have acid symptoms or heartburn, we want to look down here. So one of the things we do is we'll take a lighted telescope and look down here. It's a simple procedure called endoscopy. That's one thing we can do. Another thing we can do is we can have a esophagram where the patient swallows material and we watch it go down on x-rays, and that tells us information. Those are two basic tests that doctors might order. There are additional tests that are really interesting. For instance, when you go to the eye doctor, like I have to do every now and then, how does the eye doctor know what kind of correction you need for your glasses? They put that contraption in front of your eyes and they say, is this one better or is this one better? Right? And
Yeah.
they try to measure just where you are. and they get a number and they figure out what the right eye is doing, what the left eye is doing. Nowadays, we're able to actually measure things with numbers. And one of the ways we do that is we can actually put a probe in the lower esophagus here. We put in a wireless device that's the size of a pill, and it attaches here in the lower esophagus, and it sends radio signals out to a box. And the box is like a radio. It receives the signals, and we get information from inside your esophagus, and we can measure for 48 hours. We let you go home with the box, and the box tells us what's going on inside of you. And when you return the box to us, we can analyze the data from inside, and we can actually get a number, and we can say how much acid reflux you have. We can tell exactly how many minutes of acid reflux you have over a 2-day period.
That's great.
And
Yeah.
we know what's normal and we know what's abnormal. And then we can put you on a spectrum and decide whether you have terrible reflux or whether you just have a little reflux.
Yeah.
And so that's one thing we can do to really hone in on exactly what's going on.
Yeah. So do you normally provide all of those tests all to the same patients, or is it dependent on the patients and what they come in with their complaints?
So some of it has to do with how severe complaints are. We don't do that on everybody.
Okay.
Part of it has to do with how long you've been on medications, how severe your symptoms are, how well the medication works. Maybe you're just taking Tums and it works. If it works, it's probably perfectly acceptable to do it. If it stops working and you need to be on pharmaceutical agents, that's when things start to change a little bit.
Okay.
What we know about pharmaceutical agents is they're very safe. They were designed to be used for relatively short periods of time, but what we found out is that they're so safe that people take them sometimes for years.
Right.
That led to some studies that started to generate new data. We started to ask the question, is it safe to be taking the medications for long periods of time? And the general answer is yes, it's pretty safe. What we found out, though, is that by being on certain medications for long periods of time, we are measuring certain things in large populations where certain measurements change. So if we compare people that don't use the medications to people that do use the medications over long periods, say years, we do start to see some differences in a variety of conditions. These differences are very small. They're not huge between populations that use the medications and populations that don't.
Okay.
But we do see some trends where people that take the medications over long periods may have some increased risks. Those risks include potentially loss of bone density.
Mm.
We also see some kidney injury occurring in a few more people over time that use the medications, the proton pump inhibitors in particular.
Mm.
And we also see some increased incidence, perhaps the data shows, in Alzheimer's risk. Now, these are not things that we're altogether 100% certain about, but the trends statistically seem to show some differences.
Okay. Yeah, thank you for bringing that up. Before we move on and start talking about, the TIF procedure and how it works, we do have a couple of questions that I want to get through, if you don't mind. I'm going to read them off. Andrew saying, will I be needing my PPIs after my procedure? And do most patients get off PPIs after the TIF procedure?
So if somebody makes it to, TIF. TIF stands for transoral incisionless fundoplication. It's basically a really cool endoscopy. It's basically where we take the scope and go down the mouth, and we're able to actually do some additional things with the scope that we didn't used to be able to do with the scope. And so if somebody actually gets the TIF procedure, they have a really good chance of not needing their medications. The studies show very good efficacy of the TIF procedure in getting people off their medication for years beyond the TIF. Up to 80% of people are off their medications for up to 3 years after the TIF procedure.
Perfect. Well, that was a perfect for that. And we've got another question from Dawn. She's asking if they have if patients have asthmatic symptoms related to GERD, how soon after the TIF procedure will they resolve?
Yeah, so I've spent the last 10 years really honing in on people who have not typical signs of reflux. So people with cough, people with a sore throat, people with asthma. This question's about asthma?
Yeah.
So people that have what we call extra esophageal symptoms. So people who have symptoms that are not just in the swallowing tube, but symptoms that are in their breathing mechanism. So here's the honest answer. It's hard to predict. If we're doing an anti-reflux procedure for somebody who has a breathing issue like coughing or asthma or hoarseness to their voice, there's always a little bit of uncertainty going in about whether the procedure is going to work at all. And we have to be very comfortable telling patients to have a realistic expectation. There's a risk that the procedure won't help breathing disorders. There is, of course, a chance it will. Now, we try to do a good job of understanding whether it will help or won't help beforehand. And there's things we do in the visits preceding a procedure to help answer the question, how likely is the procedure to reduce the respiratory symptoms?
Mm-hmm.
I just want my patients to know this. The distance between our first visit and a procedure to fix reflux is likely 60 to 90 days. I really get to know my patients. I don't rush to the operating room. I'm very careful about who I will operate on, and that's why I have really good results, because I'm very careful about who I will actually do the procedure for. I want it to work. And if I don't think it's going to work, I'm not going to even offer it.
Perfect. Yeah, that's great. Let's go ahead and why don't you describe or explain, how does the TIF procedure work? What's the mechanism of action for the viewers, if you don't mind?
Sure. Let's go to the board.
Sure.
Let's see
I
if
like
we
the
can
board.
get it done. I watch those fancy whiteboard videos that are on YouTube and all over the internet, but I'm not that good yet. Maybe
I think you're
someday.
doing a great job.
I might have to take some
very-
lessons. So, okay. So what we're really talking about is the area between the esophagus and the stomach, right here, this area. So if this area doesn't pinch shut like this, okay, if it doesn't do that, then it's not going to hold the acid down here in the stomach. Material can come up when you bend over, when you eat and you fill your stomach up, the pressure goes up and material will go this way as well as this way. So the question here is, how does the TIF work? So we go down while you're sleeping under anesthesia and we put a scope down into the stomach. And then when we're down there, the scope tip has a lens on it and a light. We turn the scope backwards this way, looking up, and it looks up in this direction. And we have a TV monitor in the operating room, and we can see everything here on the TV. And while we're down there, we get a good look at this area. And then what we're going to do next is we're going to attach a special device to the scope. And that special device basically is going to become part of the scope. And it's going to look up in this area here. And the scope's going to be here looking up. And this device has a way of touching this tissue and holding it as if our hands were in there, and we can alter the anatomy of this valve. And we can create a situation where this valve pinches shut when we're all done. And we don't have to use any incisions to cut you open, because we go down your mouth and we do it all from inside your stomach. And there's some pretty slick videos available all over the internet showing this procedure in animation form, and even videos of live procedures where you can watch what's going on from the surgeon's viewpoint and what we see. But ultimately, we use special devices which hold the tissue of the valve in position. And we create a valve in a place where you've lost your valve. As we age, the valve between the esophagus and the stomach can give out for a variety of reasons. And we don't have any medication or nutritional way to repair it. It doesn't self-repair. Once it's gone and it doesn't come back, it's not going to come back. So currently we're left with having to tailor make a new one. And we can do that with a variety of procedures. The TIF procedure is the least invasive method, where we just go down your mouth into your stomach and we do some very fancy work so that when you wake up about a half hour to 60 minutes later, you've got a valve that works for the first time in probably a long time. And so that's how TIF works conceptually.
Perfect. That's a great explanation. So thank you for that. Can you talk a little bit about, what could patients expect kind of the, during the procedure? What are the things that they're gonna, are they there overnight? You did say that, you don't have to have any incisions. So what can they expect the day of the procedure when they come in to have the TIF procedure?
Well, first of all, having been a patient, we know everybody's a little nervous, but they're also a little excited because they're looking forward to life after their discomfort from their disease. So first of all, you can expect a lot of really nice people to make you feel really comfortable. Everybody knows you're nervous. Everybody that's taking care of you has probably also been a patient. So we all take really good care to make you feel at ease. After you meet a bunch of people and we check you in and we get you into your gown and we get your IV started, once everything is all ready, we take you to an operating room where you get put to sleep. You fall asleep. While you're sleeping, we do all the work. You're asleep for about an hour and a half at most. And then you wake up instantly. It's like nothing happened. When you wake up, you're in the recovery room. You're groggy. And because you're groggy, it's hard to gauge whether you're going to be able to swallow water really well after we've created this new valve for you. So what we like to do is monitor you overnight and make sure you're able to drink and stay hydrated when you go home the next day. And since it takes a while to wake up from the anesthesia, and it takes a while for you to feel comfortable just swallowing liquid, we just hang on to you and we keep you overnight and we make sure you're able to tolerate water and whatever other liquids you want to drink. And then you go home the next morning. Most people have a mildly sore throat, but other than that, occasionally they feel a little pressure in their upper abdomen and this area here.
Mm-hmm.
Sometimes they feel some pinching. It's very tolerated. Sometimes all they need is some Tylenol and they go home. You can drive. About 24 hours after the anesthesia is done, you can drive. Since there's no incisions, there's no dressings, there's some fatigue, and we keep you on a liquid diet to allow our work that we've worked so diligently to achieve, we allow it some time to rest. We want that valve that we create in this area here, we want this area to rest. Imagine you break a bone, you break your arm. Well, we put it in a cast to keep the bone together long enough to heal. So we cast you. Well, after we do this particular procedure on the valve here, we want to allow it to rest. Your body needs some time to scar. We want that area to actually heal in a manner that takes some time. So we keep you on a mostly liquid diet for the first week and into the second week. And after about 2 weeks, we start to become a little bit more generous and we expand the diet and we allow thicker, fatter things to go down the swallowing tube here and stretch the area open as it's passing. And as time progresses over a 3 to 4 week period, we graduate you to eating deep dish pizza again. So
Yeah, it's funny. I've heard some patients say immediately, and I don't know if this is true for you, but immediately after they wake up, they can already feel that their acid reflux is gone, which I think is surprising. Is that pretty common for patients to say that, or do they just have this weird sensation that they're feeling?
I have had patients say they felt better immediately.
Okay.
I see everybody a week later. I see them the morning after, and then I see them a week later.
Sure.
And usually they already know. You see, it's not just the heartburn that some people feel. It's the material coming up.
Sure.
And they know that nothing's coming up anymore right away.
Right.
And even though we keep you on your medicine for a month after we do the TIF, we keep you on your we keep you on your omeprazole or whatever medication we have you on.
Okay.
We keep you on that for about a month afterwards. And then we take you off of it.
Okay.
But remember, all those medicines do is reduce the acidity of what's coming up here.
Yeah.
They don't stop it from coming up. The TIF procedure stops material from coming up. I'm trying to get my.
You're doing good. You're doing good.
So, you always wonder how the weather-man does that, with watching the teleprompter over there.
Green screen.
Sun's
Yeah.
coming in from the west, and it's anyway. So yeah, people feel different things. Everybody's different. Some people feel it right away. Other people, it takes a few weeks for them to really fully realize it. Now, some people have had their symptoms so long, it takes their brain a while to adapt to the fact that it's over.
Yeah.
And it's like their brain cannot completely conceptualize the fact that they're no longer having the symptom they had for so long. It takes a while to recover. It could take a couple months to fully trust not having acid reflux anymore.
Yeah. Yeah. Wow. So we have some more questions. I keep seeing them. I'm looking over because they're popping up. So I just want to make sure we get through some of them. Kathleen's asking, if one has a small hiatal hernia, 2 millimeters, is that repaired transorally, or does surgery need to be done in addition to TIF?
If you're a young person and you have a small hiatal hernia, 1 centimeter or 2 centimeters, the hernia is reasonably left alone, very reasonably left alone. It really depends on how bad your reflux is. It depends on a few factors. This is an individualized situation where I really have to know you and examine you and know your circumstance to be able to answer that completely. But in general, just because you have a small hiatal hernia doesn't mean it needs to be fixed. And sometimes we can just do a TIF and leave the small hiatal hernia alone.
Okay, thank you. Greg is asking, will the TIF also help solve the constant clearing of the throat?
Well, that's one of those extra esophageal symptoms I was talking about earlier. I'd really want to interview you to be able to help predict the answer to that question. The answer is possibly yes, possibly no.
Okay, perfect. Sandra is saying, my acid reflux was gone immediately. So she had the TIF. I had no regurgitation symptoms for the first time in years. I felt well, so that's good.
Hey, that's nice.
Yeah, Kathy's saying, I have been dealing with GERD and vocal cord strain since March. I work in the same building as you, Dr. Dachman. I think it's time to meet you. Oh, that's fantastic.
Yeah, come on by. We're friendly.
That's fantastic. Okay. Well, so there you go. Let's see. This is a good one. Could the TIF procedure cure my Barrett's?
So that's a great question. So for those of you that don't know what Barrett's esophagus is when this particular area of the lower esophagus, right here, this area, the stomach has a lining that's one type, and the esophagus has a lining that's another type. Imagine your lip. It's got one kind of a lining, but on the inside, it's got a different kind of lining. And that's kind of what this area is like. Now, your esophagus doesn't like acid exposure. And if there's too much acid exposure, it starts to think, wow, maybe I'm not an esophagus. Maybe I'm supposed to be a stomach. And so Dr. Barrett was a doctor who became famous for describing when the esophagus starts to change to become more stomach-like. And the cells here change. And then what we found out was if the cells start to change, they can become troublemakers. And Barrett's esophagus, if ignored, can become esophagus cancer. So your question is, can an anti-reflux procedure, a TIF in particular, cure my Barrett's or make it go away? And here's the answer: maybe. We have seen anti-reflux surgeries cause Barrett's to go away. We've also seen anti-reflux surgeries not make it go away. Is there harm in doing an anti-reflux surgery to somebody with Barrett's esophagus? As long as the Barrett's esophagus does not have a condition called dysplasia, which is close to being cancer, the answer is definitely. However, for some people with Barrett's esophagus, with dysplasia, what's interesting is sometimes it's hard to know where this junction is. And some of the doctors that treat the Barrett's esophagus to make it go away want us to do a fundoplication before they treat the Barrett's. Bottom line, not to confuse anybody, if you have Barrett's esophagus, you're seeing somebody that knows a lot about it, probably. And they will sometimes refer you to somebody like me that can fix your reflux. Surgeons that do this work can fix the reflux. Gastroenterologists, some of them do TIF, but most of the TIF providers are surgeons. Bottom line, for further clarification, you're best seen by somebody like me that treats Barrett's esophagus and also does anti-reflux surgery.
Perfect. Thank you for answering that. I think we've got one last question. This Adam is asking, have you seen your TIF patients to have positive outcomes?
Yes. In all of the TIFs I've done, I've only had 2 people who did not have an outcome that was considered to be what we were shooting for. Here's the good news. One of the patients, we just did another TIF. It's repeatable. We touched it up and it was fine.
Oh.
The other person didn't want to have the touch up. They wanted me to go and do the more aggressive surgery where we had to make some incisions on the belly. And so we did that and they were fine. Even though we could have done the touch up for that person elected not to do the touch up, which I'll never know what would have happened if we had gone and done the touch up TIF. TIF is nice because it's repeatable and it's minimally invasive.
And they say it doesn't burn any other bridges, right? So if you decide, if it doesn't work, you, like you had mentioned, you did the Nissen or toupee after the fact, and it doesn't burn bridges. So yeah.
Yes.
Wonderful. Well, we're coming up to our hour for the evening. You've given us some really great analogies. I love the analogies you've given tonight. It's very relatable, if you will. Before we leave, though, I do want to ask you if you have any advice or recommendations for people that are watching today on what they coming to see you, of course. What is your advice to them, if they are suffering from GERD today?
Well, if you're suffering, don't. It's needless. There's help. It's really, if you're really struggling with this, reach out. We're very careful about what we do with people. We always treat people the way we would want to be treated. So we have a very methodical approach. We're very careful. Many people don't need surgery or a TIF. Some people will benefit from it. Bottom line, if you're really struggling, if you're suffering, it's just not necessary. There's help available.
Perfectly said. Can you remind everybody that is watching, where are you located and how can they get a hold of you?
We are located in Watertown, Wisconsin, and you can reach us at the General Surgery Clinic. The phone number here is 920-206-3042, and we'd be happy to schedule you for an appointment.
Fantastic. For those of you that are local in the area, you know how to get a hold of Dr. Dachman. If you're not and you're looking for a TIF physician or for more information, please feel free to go to gerdhelp.com. We do have a physician finder there where you can type in your zip code and or state, and you'll be able to find a physician that's closest to you. Again, Dr. Dachman, it was such a pleasure to have you this evening. Thank you so much for taking your time and explaining. I love it. I love it. I love the background too. But we really appreciate you, taking the time to discuss GERD and treatment options today and the TIF procedure. So thank you again. And everybody that joined us this evening, thank you for joining us for our TIF Talk. Unfortunately, this is the last one for the year. We've done one pretty much every Tuesday, sometimes on Thursdays as well. But we will be back come January 2021 for some new segments that you'll be excited to watch in regards to GERD, meeting more doctors and also meeting more patients in the future. So thank you, everybody, and please stay safe and have a great evening. We'll catch you next time.
Thank you.
Thank you.